So welcome back to the part 2 of CS of DEMS publication, Prosthodontics. We are going to study the relief structures in maxilla. So first is incisive papilla. I will be attaching the images. So elevation of soft tissue over the incisive foramen or nasopalatine. These are the relieving structures. This means that we don't have to stress them during the impression or during the impression taking or denture should not give any stress to these areas. So elevation of the soft tissue over the incisive foramina of or nasopalatine column is incisive papilla. So impingement causes burning sensation, paresthesia and pain. If a lot of impingement is given on that or more stress is given, then it will give the burning sensation, paresthesia may occur and even pain. Okay, now median palatine raphe extends from incisive papilla to distal end of hard palate. Extends from incisive papilla to the distal end of hard palate. Thin mucosal covering and non-resilient. Relieved adequately to avoid trauma from denture basis. Mostly it should be relieved so that there is no trauma. Median palatine raphe, it starts from the incisive papilla to distal end of the hard palate. Fovea palatina, bilateral indentation near the midline of the palate, formed by coalescence of several mucous gland ducts. Posterior to the junction of hard and soft palate. It is posterior to the junction of soft and hard palate. Aids in determining vibrating line according to on an average lies 1.31 mm anterior to anterior vibrating line. Anterior vibrating line say 1.31 mm जितना वो anterior है. And it is formed by collisions of the several mucous gland duct. Okay, and it is posterior to the junction. Here there will be the junction of soft and hard palate. It is posterior to that. Here there is a bilateral indentation near the, unique to humans but not a constant finding. These were the relief areas. There were the, first of all, we'll just have a quick revision of maxillary arcs limiting structures, which is labial frenum, buccal frenum, labial vestibule, buccal vestibule, hamular notch, vibrating light, post-palatal seal area. These are the limiting structures. Labial frenum, labial vestibule, buccal frenum, buccal vestibule, hamular notch, PPS and vibrating lines. Okay, now then the relief structures. These were the limiting structures. Now the relief structures is incisive papilla, median palatine raphe and fovea palatina. Now we will come to the stress bearing area, which are the very essential for the retention of the dentures. So the stress bearing structures in maxilla are hard palate and firm maxillary tuberosity. Hard palate and firm maxillary tuberosity. Maxillary ridge and rugae. Hard palate and firm maxillary tuberosity. Maxillary ridge and rugae. Okay, maxillary ridge and rugae are the secondary stress bearing area and primary are the hard palate and firm maxillary tuberosity. So it was all about the maxilla. So now we are going to the on the mandible. So mandible, सबसे पहले it will labial frenum, shorter and wider than maxillary frenum. It's shorter and wider than maxillary frenum. Now adequate relief for muscle activity, that is orbicularis oris. For the labial frenum is of mandible is associated with orbicularis oris. So we really need to relieve for muscle activity. Buccal frenum, adequate relief for muscle activity. Depressor anguli oris and caninus. Caninus and depressor anguli oris, buccal frenum and labial frenum is orbicularis oris. There are many questions related to this stuff. Buccal shelf extends from buccal frenum to anterior border of masseter. Anterior border of masseter. Buccal shelf is buccal shelf. You're right. Buccal shelf. From buccal frenum to anterior border of masseter. Okay, now boundaries. medially by crest of the ridge, distally by retromolar pad. Now, between the medially by crest of the ridge, distally by retromolar pad, and laterally by external oblique ridge. Medially by crest of the ridge, distally by retromolar pad, laterally by external oblique ridge. Between external oblique ridge and crest of the alveolar ridge, primary stress-bearing areas lies at right angles to vertical occlusal forces, with increases as resorption increases. Resist resorption due to the stimulation by muscle attachment. What is retromolar pad? It is a non-keratinized triangular soft pad of tissue. Aids in stability of denture by adding another plane to resist movement of the base. Now contains fibers of pterygomandibular raphe, fibers of superior pharyngeal constrictor and buccinator muscles, and temporalis tendons and glandular tissue. The fibers of pterygomandibular raphe, fibers of superior pharyngeal constrictor and buccinator muscles, temporalis tendon and glandular tissues. Limiting landmark of distal extension of complete dentures up to anterior 2/3 of retromolar pad. What are the limiting landmarks? It is the anterior 2/3 of the retromolar pad. Determines height and width of the occlusal table. Labial frenum, buccal shelf. Boundaries are the crest of the ridge, distally by retromolar pad, laterally by external oblique ridge. Okay, retromolar pad is a non-keratinized triangular soft pad of the tissue. It contains the fibers, it aids in the stability of denture, and fibers of pterygomandibular raphe, fibers of superior pharyngeal raphe, and buccinator muscles, and temporalis tendon. Limiting landmarks, it is anterior 2/3 of retromolar pad. Now, alveolo-lingual sulcus. It is between the lingual frenum to retromylohyoid curtain and has to be recorded in length and width to maintain peripheral shape. So in mandible we need to record alveolo-lingual sulcus, which is between the lingual frenum and retromylohyoid curtain. Lingual flange extends below the level of the mylohyoid ridge. Tongue rests on the top of the flange and aids in stabilizing the lower denture. So lingual flange, which extends below the level of the mylohyoid ridge, it helps in stabilizing the lower denture. It's divided into three portions: anterior portion, middle portion, distolingual, which is posterior portion region. So there are anterior, middle, posterior. Anterior should not interfere in lingual frenum. Okay, so anterior should not interfere in lingual frenum. Middle mylohyoid portion should be in accordance with mylohyoid muscle, which is a mylohyoid portion. It should be in accordance with mylohyoid muscle. Distolingual and the posterior region, which is anterior is also known as sublingual, posterior is known as distolingual. The flange passes into the retromylohyoid fossa. Proper recording gives typical S form of the lingual flange. Okay, the flange passes into the retromylohyoid fossa. And they typically they give this type of S form of the lingual flange. Influenced by glossopalatine and superior constrictor muscle constituting retromylohyoid cut. Diagnosis and treatment planning in complete denture. Mental attitude. House classified patients such as philosophical, exacting, hysterical, indifferent, philosophical patient. Philosophical, exacting, hysterical, indifferent, philosophical patient. For the denture acceptance is the philosophical type, and this patient is rational, sensible, calm, and composed in difficult situations. The philosophical patient overcomes conflicts and organizes this. The best mental attitude for the denture acceptance is the philosophical type, and the patient is rational, sensible, calm, and composed in different situations. Philosophical patient overcomes conflicts and organizes his time and habits in an orderly manner. He eliminates frustration and learns to adjust rapidly. Okay. Now, exacting the patient, the exacting type may have all of the good attributes of the philosophical patient. However, he may require extreme care and efforts and patience on prosthodontist part. This patient is methodical, precise, and accurate, and at times make several demands. If the patient is intelligent and understanding, he can give the best time. Indifferent patient. Indifferent type of patient presents a questionable or unfavorable prognosis. This patient exhibit little concerns, if any. He is apathetic and uninterested and lacks motivation. The indifferent patient pays no attention to instruction, will not cooperate, and is prone to blame the dentist for poor dental health. An education program in dental condition and dental treatment is the recommended treatment plan before the denture construction. Hysterical patient. Hysterical type is emotionally unstable, excitable, and excessively apprehensive and hypertensive, and the prognosis is often unfavorable, and additional professional psychiatric is required to prior to and during treatment. Okay, so the type of the patient was exacting patient, philosophical patient. Yeah, exacting, hysterical, and indifferent. Philosophical are the best type of the patient. They give time, they adjust according to our condition. Exacting patients are like, they are the perfect type of patient. They need everything perfect, and if they are intelligent, okay. If not, then it's a big trouble. Indifferent patient, a pathetic and uninterested one, and they really need motivation, and they blame, you know everything on the dentist only. Hysterical patient are the psychiatric one.